Hello, welcome everybody. I see people are signing in fast and furious, so we'll just give a couple seconds for people to join in. While you're joining in, well, if you could introduce yourself in the chat and let us know your name and what OHT or organization you're from. And while we do that, I will make sure that you're responding to everybody or all panelists and attendees rather than panelists. Cindy Bratt from Elgin, Steve Sinclair from Rainy River District OHT, welcome. Joanna Hicks, Christina Clark, Kevin. Oh, very fast. Welcome, everybody. So we'll just give it another second as we are signing on. Donna Kieran from Muskokan area OHT. We have Mandy from East York Region, North Durham. Welcome. Liam McGuire. Kevin McLeod from Muskoka OHT again. Gail Gloucester, BBN OHT. Welcome, everybody. Keep introducing yourselves in the chat. And again, just a reminder that you want to make sure it's going to everyone. And important later on when we're having some discussion in the chat so that we can all see your comments. So keep introducing yourself. Before we get started, I do want to acknowledge this land in which the University of Toronto operates. So for thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. So thank you. So before we get started into our material, we really like to hear who has joined an HSPN webinar previously. I think we still tend to have a lot of newcomers, which is great. And eventually I think we'll even out. But Anne, if you could launch this poll. So our last webinar that focused on patient experience, we had about 70% of people had been to a webinar before, and we'll see what it is this time. So it looks like a few people are answering the poll. We'll end it in about 3 seconds. And share the results here. About 80% of people have joined us before for a webinar, and 20% or just over, it's their first event. So welcome to those who are returning, and welcome to those who are joining us for the first time today. So on our agenda today is we're going to start off by providing an overview of the HSPN provider experience measurement, and then we're going to spend some time hearing from Couchiching OHT about using this survey tool with their palliative care providers. So we have a all-star lineup today. Unfortunately, Ruth wasn't able to be with us today, so I'll be playing the understudy for her section. But we have Elana Commisso, who has a background in literature and philosophy, and has been working with the HSPN team since 2017 as a research associate, project manager, supporting practice facilitation and quality improvement in the design and implementation of team-based care and integrated care initiatives. We'll be hearing from Dr. Erika Catford, who is a family physician with Aurelia, and is affiliated with the Couchiching OHT. She has a busy family practice, which includes inpatient and obstetric privileges at Aurelia Soldiers Memorial Hospital, long-term care network, hospice palliative care, and is the medical director of the Mariposa House Hospice, a new 5-bed hospice residence in Aurelia. And she is involved in teaching at University of Toronto with the family and community medicine. Also hear from Annalise Stenekes, who is a social worker by training and is currently the executive director at Mariposa House. Prior to this, Annalise has been involved in hospice and palliative care in various roles, including volunteer care coordinator and working at Hospice Palliative Care of Ontario to develop and manage programs for all hospices in the province, including standards, accreditation, and metrics. We hear from Angela Munday, who is the Director of Clinical Services at Couchiching Family Health Team. And after years of providing therapy to youth and adults, she's moved into a leadership role and enjoys working with the Couchiching OHT and service partners. She currently works as the chair of the Palliative Care Working Group for Couchiching OHT and focuses on streamlining services for those at the end of life in the region. Finally, Chris Archer is a full scope project management professional in strategic planning, specializing in aligning business goals with solutions to drive strategic and operational plans through communication. He is the project lead with Couchiching OHT and leads the digital health strategy there. So a great group of people to hear from today, and thanks to the panelists for joining us. So, just before we get started into to some of the survey information, I wanted to orient us to the Quadruple Aim. So this series of webinars that we're doing this spring focuses on a different aim and how it can be measured. And we focus on this because it's a framework that's been adopted by the ministry and OHTs. And we know that at a mature state, each Ontario health team is expected to improve performance across a range of outcomes in this Quadruple Aim. So that's 1, better patient and population outcomes, 2, better value, 3, better patient, family, caregiver experience, and 4, better provider experience. And that's our focus for today. So up until about 10 years ago or so, people often discussed the triple aim, and provider experience was added to it as seen as important in its own right as an aim, and it also is connected with achieving the 3 other aims in this Quadruple Aim. So I'll start now on giving an overview of the HSPN provider survey. So first, we found that the current measures of provider satisfaction, or previous measures, really focused on physician and nurses, and as well had a lot of focus on burnout as a proxy for well-being. So our first aim in developing this survey was to effectively capture and reflect the Quadruple Aim. So there wasn't much out there in terms of clinical experience, and still less related to population health and integrated care. So we sought to develop a provider experience survey that was applicable to all provider types, given the shift to multidisciplinary and integrated care. So OHTs are multi-providers working across various sectors, and we wanted to look beyond just the physicians and nurses and wanted a tool that resonated with all provider types, so including allied health professionals, PSWs, etc. So we also want to include multiple dimensions of experience from the provider perspective and looking at autonomy as well as well-being. And because in the context of Ontario health teams, again, we're thinking about one team across various sectors. And I will note that in the OHT guidance document, it states that the desired outcome is that providers having high level of confidence in the system, and provider health is supported. So it is set out in the guidance document. So I'll go through how we developed this survey and take you through the 3 steps. So first was a literature review of existing provider experience tools. And again, taking the provider perspective as opposed to the organizational perspective in this. We created an inventory and items from which the survey could be developed, and looking at constructs and measures that go with the experience. We used peer-reviewed journal articles and gray literature. And as mentioned previously, one of the findings was that the focus was really on physician and nursing experience and what was already out there. So the result of this phase was to categorize findings into broad categories based on question themes. So we learned what was important to measure and how it is being measured. and matching up the measures from the literature review with these themes. So as an example, looking at burnout, we learned that burnout affects all aspects in pursuit of better health and healthcare. It leads to lower staff provider engagement, which correlates with lower patient experience, lower productivity, and an increase in risks and accidents. And regarding patient outcomes, lower level of staff or provider engagement is linked with lower quality of patient care, including safety, and burnout limits provider empathy, and which is a crucial component of effective person-centered care. So an important dimension there. And we also learned about the several validated items and scales for burnout. The next phase was narrowing down through a modified Delphi process. So many of the questions came from the RAND physician survey, as well as the Goodell et al. Survey on relational coordination, which aligned with the focus of integrated care. So really, we reviewed the survey items and matched them to the categories that were uncovered in that rapid review. We found the RAND survey contained a lot of the constructs that were found to be important in that rapid review, the literature review part. So there was a careful review. That survey is actually almost 200 items. So through a process of selecting the ones that are relevant to the OHT, getting it down to 90, and then through a final process of 39 items in 5 domains. So the result of that phase, as mentioned, was the 5 domains with 39 items. So this was the draft survey, and it also is the structure for the finalized version as well. And it also has an open-ended question asking about how work experience could be improved, as well as demographic measures. No, so the final phase of development was validation. So we tested the new items in a series of focus groups with providers, so including physicians, nurses, allied health, community mental health workers, PSWs, and these focus groups asked what aspects of providers' job impact their professional work experience. So based on that, we did a review of the survey and refined on feedback and did some cognitive testing. And the result of that phase is the survey that we have today. So it is available online in English and French and on our website. And there's also some information and tools about how to implement it. I'll just take you through these 5 domains and share a little bit about what they are and what some of the questions would be. So for care coordination, there are 9 items, and these questions concern care coordination across providers that your patients receive care from. So an example being, how often do you know about all visits that your patients or clients make to other health providers? And how often is patient care well coordinated with community resources? And the sort of response scale you can see down at the bottom. For workplace culture, there's 15 items, which is actually the most for any of these domains. And again, we know that the provider engagement is linked with lower quality of patient care and important to measure. So we ask, to what degree do the following statements reflect the conditions in your work care setting? So in my practice care setting, difference of opinions can be voiced and heard, and also leadership promotes an environment that makes the work I do enjoyable. We also ask that question for makes the work I do safe. For autonomy, we know that professional satisfaction has been associated with control over schedule in your work, so an important one to focus on. In your work care setting, to what extent do you have input into the following? Allotment of additional time for difficult to help patients or clients, and things that are done in daily work. There's 5 questions on burnout or satisfaction. First is, using your own definition of burnout, please select the statement that best describes your work situation. And we'll hear a little bit more about this one from Elana later. And I receive useful information about the quality of care I deliver. Overall, I'm satisfied with my current job. And finally, excuse me, the last domain being digital or virtual care. So I think that's important for OHTs to organize. And an example question would be, we rely on electronic information systems to share patient information with other providers, and the use of digital methods to communicate with patients improves my quality of care. So that's a quick overview of some of the questions and how it was developed and what the survey looks like. I'm wondering from the audience, do you have any questions about the survey or the domains? And also, I'm wondering too, what types of discussions have you had or are you having in your OHT about measuring provider experience? So please share in the chat if you do have any questions about this, and please do share. Let us know. We want to hear from you about what your plans are for measuring provider experience. And I see also here there's a request to put that link into the chat, and we will do that. And Anne, I'll get you to do that if you can, or it'll be in there later. I can do it. So I'm not seeing many questions about the survey or the domain, so I guess that's clear in what's involved. But please do share what you are planning on doing. We will do.
We do have one question, Kaylee, about how the survey is used with different types of staff and providers. Do we differentiate?
Yeah, so it is the same survey that would be used by all different types of providers. And there's a question there at the beginning that asks what type of provider you are. So it gives us the opportunity, if your OHT decides to implement it with multiple provider types, gives us the opportunity to do some comparison in terms of physician versus other nurses, etc. So there is, we do have a question for people to report what type of provider they are, and allows us to do analysis on that.
And we have Leslie and Greg sharing how they use data related to provider experience about improving and influencing their OHT.
Great. Great, so keep sharing. We're going to launch a couple polls just to see what people are doing or planning for measuring provider experience. And if it can get you to launch poll 2. So there are 3 different questions in this poll. The first is, how has your OHT included provider experience in your measurement plans? So asking broadly about it. And then we're asking, how are you thinking of actually measuring it? So by survey or another method. And then interested in knowing if there's a particular sector or priority for measuring provider experience. So there's 3 questions there. We'll give it a little bit for you guys to answer. And in the meantime, you can type into the chat what your plans are.
And we have an interesting comment from Sandra about providers not having the time or the desire to complete a survey. And I wonder if we can return to that question with our panelists to speak to, sort of whether it was worthwhile and what they got out of it.
Yeah, certainly there is an additional sort of, it's a task to do, but I think it's really, really nice to be able to ask people and find out more information about it. In particular, the question in terms of how work experience can be improved. And with that information can be quite valuable for action. A question here, how repetitive is it to individual organization accreditation or internal measurement processes? So that actually will depend on the organization itself. I know that there are, some hospitals that are doing some, would have to do a similar survey. A lot of other organizations that are involved in OHTs don't necessarily do anything like this at this point. So for some, it'll be not at all repetitive, and others it will be, there may be some similarities. So I think one thing is when you're planning it, thinking about the timing of this survey versus what's already happening and making sure it's well spaced and appropriate for that organization.
Christine makes an interesting comment about how we can make the survey less burdensome by shortening it. What we'll learn when we talk about how we link the survey results is the survey is designed and the domains complement one another, so we can actually see emerging patterns. So it's an interesting question about whether removing items gives the same value from an organizational and kind of OHT level perspective.
Mm-hmm. And we do, it is to take around 10 or so minutes, but as more people fill it out, we'll get a better sense of exactly how long it takes individuals to complete the survey. I'll just release the poll now. So looking at the results of how has your OHT included provider experience in your measurement plans? So majority are not planning an experience survey yet. Some are measuring it as part of internal measurement and monitoring. So that's about 27%. About 20% are measuring it as part of their quality improvement plan, and 14% are measuring provider experience from their ministry OHT agreement. Thinking about how they're going to measure provider experience, it's a pretty even split. Looking at of the people who are planning to do it.
Haley, sorry, can we post the poll results? We're not able to
see. Sorry about that. Okay, so that was the first question that I read off in terms of about half are not planning to measure experience yet and where else they're planning. And then looking at how they're planning to do it. So looking at of the people who are planning to measure, just under a quarter are planning to use the HSPN survey, and about 16% have developed a plan or are planning a new survey for their OHT. And again, another 16% using another existing experience survey. And then looking at what sectors people are prioritizing. One, we're looking at almost half are looking at primary care. 34%, next highest, would be we aim to measure overall experience and not sector specific. And a couple more for some of the other options.
Can we scroll down a little bit as well? We're getting a comment from the audience. They can't see the full.
Oh.
Yeah.
That's too bad. Okay. Can you see it now? Scroll, there's a...
I'm able just to scroll on my own. So I don't know if people just tap on it and they can scroll it.
Yeah, I think you should be able to control.
Yes, people are able to. We have a really interesting question from Sandra about the value of having one survey that can be used across all OHTs so we can gather data sort of more broadly and understand things at a provincial level. I think that's a really important point, Sandra, and people are at different places with the tools they're using and organizational requirements. But
yeah, it is a nice opportunity if we can do some comparisons by OHT and really highlight if there's areas that certain OHTs are doing well in or poorly in, and get that comparison to see what is behind that. And there's an opportunity from learning as we compare across. So it is a, you know, if we can use the same tool, it provides that opportunity. Okay, I think, Elana, are there any more questions that we missed?
I mean, there have been some great comments from Joanna. I suspect someone else is using her account. So maybe we can scroll through them as I'm moving forward, because there's a series of comments about organizational and sector level provider experience measures and other things, kind of robust and thoughtful comments.
Okay. So I think with that, we can keep the chat questions coming, and we can try to answer any ones that we've missed at the end. And also, if we do miss any, we can follow up over email or post some responses on our site as well. But I will move us on to hear from Elana, who's going to talk about her experience of sharing the results with the Couchiching OHT.
Yeah, thanks, Kaylee, for breaking down the survey and the survey development. I'll share that the palliative care working group at Couchiching OHT were eager to release the survey. So we began releasing it, and the survey was distributed throughout the summer and early fall of 2021. 78 individuals in the region were identified as providers of palliative care. And like Kaylee said, professional designations range from physicians to nurses, allied health professionals, as well as PSWs. We had a 45% response rate to the survey. So we then collated these data and took them back to the working group. And you'll see that overall, the average domain scores were relatively okay. But the way that we brought the data back to the working group was to support them in their planning and activities and resource allocation. So we took a quality improvement lens and we sort of dug into different domains and specific items within domains. We don't have the time to go through all of it here, but we'll look at 2 examples domains. So the first domain we looked at in the working group kind of survey data discussion meeting was care coordination. So maybe we can move to the next slide. Right. So you'll see that there were 9 questions within this domain, as Kaylee already mentioned, and scores were quite high for some of them. And you'll see the 2 highlighted, questions 3 and questions 9. The scores were a little bit lower. So we wanted to actually look at what was happening there. And maybe Kaylee, we can move to the next slide where we sort of highlighted those 2 questions. So it was by the time we brought the survey results back, the working group had made a ton of progress in identifying areas for improvement based on the knowledge of providers and participants in the group. They already knew that there were issues around care coordination and sharing of patient information. So bringing these results back had a double function. One, it validated people's experiences on the ground and also validated some of the decisions they made and resource allocations they made by trying to focus on creating centralized referral pathways, as well as kind of engaging with the digital health working group at the Couchiching Ontario Health Team. And I won't get into it all, and I'll let our panelists speak a little bit more, but this was heartening because they were moving in the right direction. And now we'll move to the subsequent slide, which was around provider satisfaction and burnout. And as Kaylee mentioned, a series of different items kind of comprised, or the domain comprised a series of different items, and one very particular question, well-validated question around burnout. So back to Sandra's point, yes, people are burned out. It was not surprising to anyone when we brought the results back around burnout. And there were some interesting findings, for example, that physicians reported higher levels of burnout than non-physicians. The value of bringing these data back, so yes, 67, thanks Kaylee, 67% of physicians compared to 27% of non-physicians. And this was surprising to many of us. The burnout actually reflected things we saw in other domains around organizational culture, around autonomy. So there were themes that moved across domains. The value of bringing these data back were that it led to a really generative and thoughtful conversation amongst members of the working group. And I'll let them speak a little bit more about that. But it also helped them think about how to prioritize activities and sort of priorities and OHT resources moving forward. We'll look quickly at the other items in the satisfaction domain on the next slide. So another thing that stood out, right, very low score, was the question around compensation reflecting the value of contribution. So this actually points to a broader system level issue around how different professionals are compensated across sectors. And while there wasn't something specifically that could be addressed at the OHT level, this really starts to inform staffing complements and how to think about, making sure people feel compensated for the work that they do. So we brought these data back, and just to sum up, we really took a quality improvement and kind of learning-oriented perspective to how the data can be used to support the work of the working group and the broader work of the OHT. I think now we'll turn, actually, I don't know if we have a poll. Yes, we have some questions, right? So we will turn to the participants, and maybe they'll turn their cameras on, and Kaylee has already introduced them all.
Yeah, and I'll just, just to interject a bit, if you have questions as we're going through, you can feel free to enter them in the chat, but I do want to make sure when you go to the chat that you're sending your question to everybody. So there's a little drop-down menu. So that way everybody can see the question, we can respond to it as an audience. So I just wanted to flag that before we move, and feel free to ask questions as we go, and we'll stop at the end for additional questions.
Okay, so we'll turn to the members, our panelists here. Thank you for being willing to share your experiences of interacting with the survey and using the survey data to inform your work. The first panelist that we're going to turn to is Angela. There she is, right?
I'm here.
And Angela, as one of the co-chairs of the palliative care working group through the Couchiching OHT, could you just briefly share with our audience a little bit about why the working group decided to use the tool?
Absolutely. So I should start by saying that palliative care was identified by our OHT as our year 2 priority population. We already had our palliative care working group in existence. So it, was a really natural fit for us just to continue, broadening the work that we'd already started doing. So one of our goals as a working group was to identify the pressure points in palliative care. We knew there were a lot of people doing, lots of different pieces of the work, a lot of duplication, that sort of thing. But we wanted to know, before we got into the work of streamlining, which was our main goal, streamlining palliative care resources in the region, where are the pressure points? And then that would in turn help us to identify where the gaps are. So we had talked about doing a survey ourselves, and then lo and behold, we had Elana and Ruth coming to the meetings, and that's when they shared the tool that they had, and it was a no-brainer for us. It was a very quick decision that yes, we're not going to reinvent the wheel. This is exactly what we're looking for, and HSPN really ran with it from there and made it much easier for all of us. So what we really liked about the survey is that not only the breadth of information that we could get from it, but that we could look at it by discipline. And again, that's going to help us as we look at where are there pressure points or gaps in services, and kind of help us focus in our streamlining process. Where do we need to put our energy right now? What are the priorities? So
thanks, Angela. And we'll come back to you for some more reflections.
yeah.
So Erika, as a family physician, palliative care physician in the Orillia area, Dr. Erika Catford, could you tell us a little bit about your experience of reviewing the survey results when the results were brought back to the working group?
Sure, thanks, Elana. So just a quick background context for the people on the call. So in Orillia, we don't have a specialty palliative care physicians. So I know some communities do have palliative care sort of specific physicians or expert physicians. In Orillia, we, as all the family docs, we do our own palliative care. And we have a subset of that group, about 14 of us, who will help and support unattached palliative patients in the community, or people who need a doctor in our hospice and so forth. So just a little background there. So I think the biggest one, and thank you, you highlighted in the yellow on the bottom one of your slides, was, I think, reflecting on, you wanted me to reflect on my experience of seeing the survey results, was recognizing that physicians amongst all the other staff are experiencing burnout. And I can see in the chat, like the comments of like, well, we already know there's a lot of burnout in healthcare. And then I just never saw the physician group as having perceived, more burnout, if you can qualify it, than our other counterparts, or their, nursing counterparts and nurse practitioner counterparts, and the PSWs who also filled the survey out. So I think that was a bit of an eye opener for me. And, I think the pandemic has been a tough time for all of us, and especially in this community where, like I also do long-term care, as mentioned in my bio, and, crossing sectors. And so a lot of us family physicians, and in particular in smaller places who are crossing a lot of different sectors, are really, really pressed. And so I think this survey really helped to identify that. And it was a bit of an eye opener for me, because I think, we always think we're fine and say we're fine, and then realizing, oh, geez, maybe we're not fine. And looking at where do we go with this and how do we take that forward, I think has been, we've really in Orillia been trying to build a team and get away from silos in palliative care, and working together with all our partner organizations. And so I think that, recognizing that is also helping us to build that team, and recognize that, by doing so, we can reduce burnout in any one particular health profession, and we can, use the team to help come up with that solution. And I think there was another chat about how it was Cheryl, I think, like, can you link burnout to other pieces in the survey, like care coordination and so forth? And I think that's a really good question, a really good comment. I don't know if it can be addressed by yourself or someone later in the call, but it did force us internally to start thinking about that.
And when we reviewed the survey results, we saw themes across domains related to burnout, related to autonomy, related to enjoying their leadership and experience of work. So how do you see these data from your perspective, Erika, moving the work of the working group sort of as you progress? Do you have any particular thoughts about that?
I just think it's really validating. It's been really validating for us because it really gave us some numbers and some objective data to what we were already kind of feeling. And then there were a few little surprise things there too, I think, but by and large, I think that's what it does, is it really validates that we are on the right track, and the things that we're trying to do around care coordination and single source referral and single entry in the system, making it easier for providers, linking, all the other services together, wrapping around the patients, the whole goal, like one of the big things of the OHTs is bringing that whole community together around the patient. So I really think it's just more validated the experience for me.
Thank you. Thanks for sharing. Yeah. So I'm going to turn now to Annalise, who is the Executive Director of the Mariposa Hospice, which opened its doors in the winter of 2021. So can you share with us a little bit what the data brought to you, or what the sharing of the survey results brought to you, both from an organizational perspective and somebody who's been working in hospice palliative care for many, many years?
For a while, sure. So yeah, similar to Erika, I'm just going to provide a little bit of context that many people might hear the word hospice and imagine that the hospice that's in their local community, but hospices do look a little different in communities across the province. So for context, Mariposa House Hospice is a 5-bed hospice residence, and it's a brand new organization that became incorporated in late 2016, and the inaugural board of directors at that time were the ones to really get the engine to actually get the funding organized and get the building designed and get the building built. And then I was the first employee hired in May of 2020 to kind of turn it into an operational organization. So it's really brand new, which is, I think, fairly unique in the healthcare sector. You don't typically have a lot of brand new charitable organizations in the healthcare sector kind of starting up these days. So a lot of unique kind of challenges to overcome to kind of get up and running, hire an entire staff team, and just launch and open the doors and be running a new organization.
In the middle of a pandemic, I would add.
In the middle of a pandemic. And the other piece, just context-wise, is that it's a 5-bed hospice residence, and we're a separate organization from the already existing community visiting and bereavement hospice program, which is Hospice Aurelia, which has existed since the 80s. So in many communities, for the people in the audience, in your local community, those two programs, hospice programs, might be under one entity. In our community, they're actually separate organizations at this point. So it's just an important factor, because for me, coming into this role and getting this, us as a team getting this organization up and running, we have a very, very lean staff team. So it's myself and a clinical manager overseeing the clinical delivery of care with the RNs and PSWs, a facility person, and an admin person. That's it. So for me, as a executive director of a brand new organization that just opened in the middle of a pandemic with limited staffing, this survey was a gift dropped from the sky above because it's obviously, I am a huge believer in data and in feedback and having mechanisms for feedback. I wasn't going to be able to do that on my own. with the limited staff team that I have. And I am part of this larger system of palliative care in the Couchiching OHT. So this was, for me, a perfect opportunity, given that we just opened our doors a few months before our group decided to kind of endorse and be the guinea pig for this survey. It was really great timing for me, because it's basically taken what anecdotally I understand this is a great place to work and people find great meaning in doing this work. But I can't really base, business decisions around running the organization on anecdotal information. So this is giving me real data and real information that I can, help me make decisions on what to prioritize with very limited resources. So for those who don't actually know, funding for residential or hospice residences is the funding from the government is only part of the operating budget, and it's really targeted only to the provision of care by nurses and PSWs. Everything else that it takes to have the setting in which that care is provided is funded through fundraised dollars. So things like pension benefits, those things that many of us take for granted when we start a new job, here, those aren't taken for granted. That's a huge, huge, introducing a pension, for example, for our staff is a huge piece of, it's going to be a huge decision when we get to that point. And I know many other hospices are the same. Some are offering pension and some aren't. But this information and some of the feedback I got through this survey highlighted for me how important that is for staff well-being, to kind of put that up at the top of the to-do list, if you will. So anyway, I could talk on and on, but I mean, that's the core of it for me. Is timing wise, it was perfect because we had just opened, so it's giving me baseline, and then I'm hoping we're going to repeat the survey year over year and see growth and movement. But even if the organization had been around for a while, I think it's still, when you're an organization working with really limited resources, this is a huge, it's a wonderful resource to be able to rely on this information and actually not have to do any of the work yourself to gather it. So
I promise no one was paid for their participation in this webinar. I should just, no conflicts. But Annalise, you sort of preempted Christina's question and my follow-up question to you about how you may use these data moving forward. So for you, it sort of shifted your priorities as a leader about how to support your staff. Are there any other things that you might like to highlight in terms of how you think you might use this?
Well, I think I could probably speak to that better after we repeat the survey, whenever we're going to do that, which I don't know when we are. Because we were so new, and I don't know how. I'm just looking actually at the demographic results. I think less than half of our staff team filled it out. So I remember sending it out a few times and encouraging people to take the 10 minutes to complete it. It was over the summer and we had just opened. So for me, I think, I'm not sure there's any other actionable other than that pension piece. It was a highlight for me that I saw it in the feedback. But I also seek some internal feedback from the staff, but it's not so much about the provider experience. It's more about, what do you need from me as an employer? So I do also have some internal feedback mechanisms. But I'm not sure there is anything else actionable for me on this first round, but I anticipate as we repeat it, it's going to give me more actionable, and as I get more folks from within my team to respond to the survey, and also after I talk to Elana and Ruth about whether or not I can parse out the people from my team that answered it, if I can see only those results, because I can see how many identified hospice as their work setting. So that's another thing that I'll take away from this, is figuring out how can I actually access the information from my employees? Because I'm looking at it again from an organizational employer perspective, whereas palliative care, like this was actually disseminated amongst our whole, all the palliative providers in our OHT. So I'm looking at the data from a slightly different angle, I think.
Thank you. Thanks for sharing that. So Angela, we're going to come back to you now, right? So as one of the co-chairs of this working group, supporting a variety of different organizations who collectively comprise the provider workforce, what was your experience of sort of how the data landed, or what the value was to your working group when the data were presented back to you? Do you have reflections to share?
I think we were all really encouraged to see how many people participated. I think a 45% return rate is nothing to sneeze at. It's hard to get people to participate in surveys. And it kind of opened our eyes, I think, across the different disciplines and organizations about where the needs are. So we've kind of started to have discussions now as a next step around what do we do with this? And the plan is absolutely to repeat the survey. That really is our goal. And it would be interesting to repeat it once we've had a chance to look at how can we address some of these things, to see if we're actually making any headway, right? But I know at our last meeting, I walked away from that meeting feeling very humbled. I mean, I'm in leadership, so I'm not boots on the ground, front line, like Annalise and Dr. Catford doing this work, right? So I was very humbled by what those folks in the front lines go through every day, and what they have to manage in terms of their own personal wellness. But we had some discussions at our last meeting just last month that really highlighted some areas that I think we need to look at them. We need to look at them further. I mean, we're worried about our physicians. That 67% feeling that they were experiencing more than one symptom of burnout that wasn't going away. That's troublesome, because we look at those folks, our physicians, as sort of the team leads for that patient, right? And the entire group of professionals that are around that patient and their family. So, we have to do something about that. We can't have the very top of the pyramid here crumbling. We need them to be strong and still feel like they're able to manage. So something has to happen there. I think another couple of comments, if you want to hear this stuff, that came out of this discussion that really landed with a lot of us, I think, were we need to make sure that we provide safe spaces for all people working in palliative care to come together and have those honest discussions about how they're coping, what they're seeing, their well-being. And really, I think it's really important that people are able to be vulnerable and say, I'm not doing well, or I don't know how to move past this one. And one example that was shared at the last meeting was around MAID and the human resource crisis that we're experiencing. And this one really kind of still sits with me today, that one of our care coordinators said, I'm pretty sure that the last client I lost chose MAID because they could not get any PSW support, any nursing support in the home, and they were worried about the burden they were going to put on their family. And that just really, I think, resonated with all of us and said, that's no reason to choose MAID. Choose MAID if you want to, but how can we as a system not have that happen? So I worry about that person who's sitting with this info and thinking, I'm pretty sure this is why they did MAID. So I think we really have to have that place where we can have those honest discussions and say, this doesn't sit well with me, or I don't know where to go next. I don't know how to handle this. I don't know how to make myself feel like I'm coping with this. And I think if we can do that, we're going to be, unstoppable in terms of our strength. And then I think the final big piece that came out, and, poor Chris, I'm going to lob this one directly at Chris. And we had a lot of discussion about the digital strategies that are being put forward from the ministry through the OHTs, and a lot of discussion that digital strategies are great as long as they don't add more work. They have to help. They cannot add more work, because nobody felt that they could deal with that they couldn't have a digital strategy to put more on the plate.
Thank you. And thank you all for sharing so honestly about your experiences of interacting with the survey and sort of the ways in which it was validating, and also sort of shone a light on things that were hard to hear and make space for. So I'll turn it over to Chris now, unless there are any questions from the audience for our panelists. and Kaylee and Ann are monitoring the chat. So if there's a question, they'll let us know. And Chris, you're working now sort of at the OHT level, and you're project lead for a number of different projects and digital strategies. From your perspective, what's the value of something like a provider survey for the OHT and for the work that you're doing from an OHT perspective?
Thank you, Elana, and Annalise, Dr. Catford, Angela, you're wonderful people and wonderful providers in our area. I just can't say enough with the work that you're doing. So thank you for sharing today. I want to talk a little bit about, kind of the OHT, and, you look at the quadruple aim, and really we're looking at improving, as category 4 work life of providers. So for us, it was, so what does that mean really? And without data, Annalise, to your point, you really don't know where to start. Not that there's beautiful solutions all in place all over the place. You have to work out those as well. But for us, that was the most important piece. And with Ruth and Elana being involved early with the palliative care working group, allowed us to introduce the survey, get the results, work through what that meant. And again, thank you for a lot of the heavy lifting that happened. And then you get the feedback and you get the results. And I think Dr. Catford said it really. It just gives people an opportunity to say that we're not okay. And what a powerful thing. I mean, just to have that, and then to see obviously the physician group and the number of respondents or whatever that define burnout through the categories, and have 40% and then 67% physicians. It's really something that's worrisome. But it's really then the next. So what is the next step? What do you do? And I think a lot of things were shared here today. I know we as a family health team or whatever, we have 9 hours of wellness training to kind of hear more, learn more, and it starts the conversation. And so for us as an OHT, started with palliative care, is we've moved now to social determinants of health working group as well, where we'll do a provider survey. And then it becomes an ongoing built into the work that you're doing in order to look at change, look at your baseline, look at change over time, what interventions are successful and what interventions are not. So really, it's about that, but it's also about understanding, what else is on providers' minds, right? Providers often can't find available services in community for their patients. They don't feel connected to professional supports, and like training or access to specialists for patient referrals is difficult, right? So for us, it's generated a very healthy conversation and has allowed people to engage. So I'll leave it at that for now. Where we want to get to is that providers are working in a team environment and have access to a full continuum of care for their patients, as well as continued professional development support and resources across the OHT. Big task, but the conversation started, and that's important.
Thanks, Chris, and thanks for
Can I
sharing.
add one thing, Elana? Do you
Yeah,
mind?
please.
Sorry,
No,
just
please
as
go
Chris was
ahead.
talking, and I'm listening to this go on, and I'm thinking to myself, as I just received my issue of our physician periodical here from the college, that's our front page, and I'm looking at this thinking very, very topical. That just came in the mail. But I think of it, and I see this survey related to palliative care and so forth, and the burnout isn't so much the clinical job, right? And so where is that coming from? Because you're right, burnout is such a big topic, and the reasons for it come from so many ways. So I think exactly that, starting the conversation. And I'm just sitting here on a personal level reflecting, what causes the most burnout? And I know I've talked about it in the group a little bit as well, but just to share to this group, I think the information overload for physicians, especially family physicians, where we're copied on reports from every subspecialty that we send our patients to, and yet we're also the people that get all the requests for insurance letters and forms. And my kid has a runny nose, they can't go to daycare, I need a note to say that they always have a runny nose. And these constant requests for paperwork that detract us away from patients is where that's what's causing my burnout. The things that are preventing me, the 2 hours, 3 hours a day I'm doing paperwork, that's preventing me from being on the front line and being with my patients, is what creates the distress, because I feel like my job as a family doctor is to serve my patients. But when I'm tied to my laptop for 3 hours before I even get to work, or after work when I can't be at my kid's sporting event because I'm so swamped with paperwork, that's what's creating the burnout, in me personally. But I would wager to say that experience is probably shared from more people than just me. But yeah, dissecting the burnout is the next step, right? What's causing it, and then where, what my family doctor hat on is, how do you diagnose it, and then how do you treat it, right? Like, where is this coming from, and what's the root cause, and then how do we get at it? So anyway, sorry, it was just a little reflection that came from what
No,
you were saying.
Erika, I think that's really important, because we saw in the satisfaction domain items that people are satisfied with their jobs. They love the work they're doing when they can do the work that they want to be doing. And I think listening to you all, at the individual provider level, at an organizational level, to work, like, running regional working groups, and from the OHT level, is that we're shifting the way of thinking about this as an individual problem, or as to a kind of OHT level phenomenon of how do you support at a system level providers across your community. And I think, thank you all for sharing so honestly, really, about the challenges and the successes of the work and where you're going. Yeah.
I'll also just quickly add, this becomes a leadership discussion, right? In terms of what needs to happen at your individual organizations as a larger OHT. Work has changed, right? How people come to work has changed. And so the idea of everyone being there, that environment is so different from what it used to be, that management levels and leadership decisions need to change and evolve as well in order for this to all work synergistically together. I just wanted to add that point, because it's really, really an important leadership discussion.
And I think we have a few little thoughts and comments in the chat. So first of all, great work, Cooch. People have to sign off that they think you're great. Yay. And Sandra's asking, Eric, I believe in response to your point about all of the administrative things, what could be offloaded to other individuals? And I know that this is a prickly question, but perhaps if we take an OHT lens to this, it gets shifted when you have better care coordination, the sharing of patient information. But Erika, you might want to speak to it from your perspective.
Yeah, I could probably go on and on, because I have been lately doing a lot of thinking about this. But for instance, like, every family doctor is now copied on every single COVID vaccination. I have got to click review on every COVID vaccination. I think we need to really look at push versus pull media the same way we look at, like, I don't have cable. I pull my news, I read what I want to read when I check my phone and read the news outlets, right? Whereas family doctors, we've use this, HRM and big data management to, like, push everything out to family doctors. Like, so the COVID vaccinations, I could go on to Covaxon and retrieve which of my patients need vaccination. I can retrieve reports. Why do I also need to be pushed those reports? Every X-ray ordered by an orthopedic surgeon and fracture clinic. Why do I have to receive a copy of every X-ray when I'm getting also a letter that's, being reporting on that? Every piece of blood work from an oncologist. So I think, to the question, I can't have staff signing off on that, because the College of Physicians says I am medically legally liable if there was a fracture that's missed somehow in fracture clinic, and I've also been copied, I'm liable. If there's an abnormal potassium on the oncology blood work, I'm liable. So it's very difficult to delegate those tasks, because the College of Physicians and Surgeons in Ontario says I am responsible for anything that I get sent. Even though I didn't order it, I'm still responsible. So there's a huge burden to hold on to with that. And it's not easy to delegate that. I've tried. I've worked with NPs in my office. I've hired them under myself, like as an office associate, and PA. I had a PA for 3 years. So I tried that delegation strategy, and it doesn't always work out. So I could do a whole other webinar about that.
And maybe you will.
I think we do have to think a little more critically about push versus pull. If we're asking our primary care providers to be on the ground, keeping their offices open through every day of COVID, like I have, and we're asking them to review all this, it's just the roles keep growing and growing and growing, and people, I don't think can keep up with it. And I've mentioned it before, a lot of our retiring physicians, it's taking 2 new family physicians to replace their 1 spot in the OHT. So why is that? We need to ask ourselves, why is that? So I don't know, a lot of work can be done there, but I don't want to distract from what we're talking about today, but it is a part of it.
Thanks, Erika.
Yeah, a couple of comments in the chat related to that. Sort of the CMPS and CMPS have clear statements about liability and accountability for regulated professions. CPS is incorrect in their interpretation. I think, one thing that, as we're talking, stood out, and earlier questions kind of about the survey itself, in terms of, is there a smaller set of items we can look at, or, shorten it in a way? But I think having the detail does provide a lot of value. As you mentioned, the overall satisfaction, if we're just asking that, which is, you might think is a great sort of that high level indicator over time about whether people are satisfied. But then when we want to get into understanding why that is, there's really the opportunity from understanding the other questions and seeing where there's areas for improvement, and even not just really promoting that opportunity to have discussions around the data, and that some things might come out of that. So I think that really stood out. So I just wanted to highlight that. There was a question back, I think, just about looking at kind of the objectives of the working group and how, I guess, so I think this would be a question for Angela in terms of your objectives of the working group and how the survey helped you sort of achieve that.
So I think the working group, we've been working on a few different things. So streamlining palliative care resources in our region, reducing duplication, making it very clear for patients who to call when, because we'd heard from patients that wasn't very clear. So that's probably been at the top of our list in terms of our goals and objectives as a working group. And this survey really helped us with that first piece of where are the pressure points. And once we're able to identify that amongst providers, this kind of is opening the door for us to have those discussions now about, okay, how can we ease the burnout while streamlining resources and ensuring that we are, using all of we go back to the quadruple aim. Are we using our resources in a fiscally responsible way? Are we taking into account the provider experience, the patient experience, all of that? So this is one of those pieces to that puzzle that I think is absolutely essential. I think we tend as organizations in healthcare really do a lot of surveys with patients, patient satisfaction, that's standard stuff, but we don't always stop and say, how are the providers doing? And really give people the time and space to say, what do you think would help based on what we're hearing, So that's what we really want to do next is kind of look at where are the pressure points? What do you as a group of palliative providers think is really going to help? And that I'm assuming and I'm envisioning that's going to help drive the streamlining process of palliative services in the community. I don't know if that makes sense. Yeah, go ahead, Annalise.
My thought was on, I just had a slightly other thought, if now's an okay time to share that. So it's kind of touching back on what Chris was saying earlier about leadership. And I think, what does leadership look like now, kind of mid to post pandemic, where maybe in some settings people aren't coming into the office as much anymore. In my setting, they are, because you have to be here in order to actually do your job for most of the staff. But in my setting, the leadership side of it, what I've been mulling over a lot, and some of the survey results play into this, is how do I do team building and the workplace culture stuff when it's a 24/7 schedule and half the team's always sleeping. So I can never actually get the whole team together into any kind of team building session, or that whole practice of leadership when you only have half your team at a time. So what I've been sitting here thinking about is the workplace culture section. And I was just kind of reviewing that again. And one of the things I'm taking from the survey results and hoping to build on is a lot of the statements. So there were 15 statements in the workplace culture section, and a number of them I think I'm doing as the leader, but when I read them, I think, I wonder if my team knows that that's actually something that I'm trying to do as the leader. So one of the things I'm taking away from the survey is, how can I better communicate with my team so that they actually understand what are some of these things that we're doing, so that next time they fill out the survey, hopefully they're filling this section out in an informed way. Because partly what I wondered with the results from that section were, do people actually know? An example is one of the statements says, financial decisions are made with clinical provider involvement. Well, in my setting, that might not be obvious to people, but I am actually leaning on input from the clinicians that work here in making the financial decisions, but they might not realize that, right? So there's this whole piece around the survey that there's a nuance there where I feel like in some ways they're filling it out, but they might not have all the information. So that's really important learning for me in the leadership role of the organization. How can I better communicate with my team so they understand some of that nuance? Anyway, sorry if I'm babbling, but that was one of the things I took away from the whole survey results.
Thank you. There is a comment. I wanted to circle back though, because early on, there were a lot of comments in the chat around the burden of the survey and burdensomeness of accreditation. And I'm wondering if, having gone through this process, if sort of, you've spoke positively for the most part, but can we demystify a little bit sort of the black box of the burdensome survey, right? So what, if you were to speak to people at other OHTs in leadership roles or organizational directors or as, frontline providers, what is it you would say to them about burden versus value, or was it really that burdensome? It takes 10 minutes to complete. Just if there are any thoughts that you can share with the audience around that.
I would say, Elana, that having this survey done for us and done by HSPN did the heavy lifting, all of the heavy lifting. The bulk of the work on my end, honestly, and I'm not even making this up, it was minutes. I just had to put a list of people together that HSPN should send the survey out to. That's really all there was. I didn't have to create anything. I didn't have to collect anything. And then magically within HSPN, Ruth and Elana presented us with these lovely spreadsheets of results and then discussed it with us at our meeting. So honestly, it couldn't have been an easier process. And if we had to do this on our own, we probably, Annalise is smiling, we might be getting the survey out now. Would you say, Annalise, is that fair to say? Maybe we might be getting it out now. So, and I love, somebody commented on this earlier. Wouldn't it be great if across the province, everyone was using the same survey and the kind of powerful results we would get from that? That would be incredible. So from my perspective, it couldn't have been easier. It was absolutely not a stressful process, not a time-consuming process in the least.
For the people filling it out, though, I think, I would probably say the same thing. I think it's about 10 minutes, but people have to have their brain in the right place to, be able to give feedback about this type of stuff. But the feedback I got from my staff was that it wasn't cumbersome to complete. I think it's a function of how much importance, if the boss says to do it, then hopefully most people are going to do it. But I think a second thing I haven't done yet, which is I haven't circled back to my team with like a report. So we talked about it, as everybody's discussed today, sorry, what's our group called again, Angela?
The working group level.
At the working group meeting, we discussed it, and Elana and Ruth brought back an Excel document with the reports, and then another, I think it was slides, so reporting back. I haven't disseminated that back to my team, and this conversation has been great because it's making me think. I think the more you disseminate back to the people who filled it out, this is what we learned, and this is what our working group /OHT /organization, this is what we kind of learned from it and are thinking of doing. I think if we close that loop back to both my employees that filled it out, but also the broader group that filled it out, I think circling back to the respondents will help sell future participation.
I thought you're just trying to buffer the score for next year, because then they'll be like, yeah, the leadership's responsive and they listen to me. if I can add one thing to your comment too, is just I was actually by the person who said, yeah, are people too burnt out to even fill out the survey? And I thought, if the 67% of physicians that did fill it out were burnt out or had that level of burnout, what would the people who were too burnt out to fill out the survey, what would their score be? So I don't think I want to know that, but you know, it's a very telling thing, right? Like, because it's the survey bias, right? It's the bias built into it.
I would also say that I think it's helpful to have HSPN be the ones doing the survey rather than say me as a director at the family health team saying, I need you to do this survey. I think it just adds that level of anonymity. And again, maybe helps to promote some of that, you know, you can be vulnerable, you can be honest, you can share exactly how you're feeling. And knowing that it's, you know, not coming directly to me, and I know only having 2 palliative care nurses, it's going to be one of those 2, right? It's I think gives some more anonymity, which is a good thing.
Yeah, I'll just comment on that as well, because there's been some comments too. So on the link, there is some resources in terms of how if you wanted to implement the survey, what you would do. So we do have one link that we can create for your OHT where the survey is done electronic and you can distribute it, and we can work with you on that, and we'll hand back the data. The turnaround time for that depends somewhat on your OHT. We like to run this survey for 4 to 6 weeks to get people the opportunity to actually respond to it. And then I think we have perhaps it might even be a month turnaround time. But I think it really depends, right? If more people are becoming interested in distributing the survey, it might slow us down in our turnaround times, but we do turn back the data around and have a template for that. I will say too, in terms of anonymity, we won't, depending on the numbers. So if the numbers are smaller than sort of, for example, less than 5 physicians answer the survey, we can't provide that back just to protect confidentiality and people who are responding to this survey. So we do have our sort of data cleaning and appropriate processes that we do before we send the data back to you so that it remains anonymous. And then there was a question early on too about from Joanna or one of her colleagues. As a regional provider participating in 4 OHTs, there's a lot of assumptions about what the OHT level of care is and what's important that the survey outlines, who the members of the OHT are. So I want to comment on that there are different ways of using the survey. So Couchiching used it in a very focused way. I know that there are other OHTs that are planning on using it more broadly with every provider in their OHT. So that would be every physician in the area. And then for all organizational members of the OHT would be their either staff or providers that they contract. So doing it more broadly. So it is really up to the OHT about how best you want to use this information. I think doing it broadly will provide a nice baseline over time, and there's still the opportunity to sort of isolate certain, I guess, groups within that to have an understanding of how the groups compare. So that's a nice opportunity.
And there's a question in the chat. Oh, somebody responded. Great. Yeah, about where the data sit.
Yeah.
And the way that Couch has used it also reflects its development, right? So certain working groups are further ahead in their ability to address particular priority population needs and issues. As developmentally, as the working groups move forward in their work, they're using the data to target supporting providers. And I suspect over time that may change the way that the survey gets used as the OHT becomes increasingly more integrated, right? And its working group work overlaps.
I think we've gotten to a lot of the questions, but if you do have one and we haven't answered it, you can pop it in the chat again, or we'll try to do. There are a couple comments about thanking Couchiching for sharing, and Erika in particular, in terms of sharing the physician perspective that we don't always get to hear from and understand what sort of the pain points in the rules are and how to make it better. So it's really nice to get your honest reflections and everyone in this groups as well. So please, if there are any more questions for Couchiching, please ask them. I would be interested in hearing from the audience if you could share in the chat sort of what value would measuring provider experience bring to your OHT. So thinking about what, if you were to do this, what value would it bring? I'm also interested, we talked about a lot about the processes of using data in some of these discussions. I'm wondering if people have sort of these processes or structures in place to be able to use this data. So if you get a spreadsheet with this data back from HSPN, would you know what to do with it? Do you have a group that you can discuss it and understand the sort of quality improvement processes that go with it? So if you'd want to share, we'd be happy to hear from you.
Colleen, retention is a big issue, right? And the Great Resignation, retaining staff and supporting them. Thank you for adding that.
Yeah, we do know some OHTs are expecting additional sort of human resources challenges coming up, and this can help sort of figure out what some actions are to prevent what we can. Creating a baseline for OHT would be very valuable. Each OHT would have a primary care engagement table. Survey helpful in identifying what to prioritize for sure. Another comment back to Chris Archer's comment, the quadruple aim should include comparison of provider to patient client experience and the value of outcomes cost for the full picture. So I think understanding each of the components of the quadruple aim will help us understand the connections as well. Great. I'm going to launch one last poll, which is just sort of asking what your intentions are in terms of how likely do you think you would be to adopt the HSPN provider experience survey over this next year, so ending in December. And this gives us a sense of sort of planning and what we can do to support OHTs. I'll leave that open for another couple of seconds. And then just close that in a few seconds, and I'll end the poll and share. So looking at sharing results, a little over half, almost 60% would be somewhat likely to implement this survey. 17% very likely, 14% unlikely, and about 9% certainly not this year. 3% are definitely doing it this year. That's one person. So with that, I will say, so I think the link is posted in the chat a couple times, but you can go to our website to see, so there's a paper copy of the survey in English and French, as well as a video that walks you through the steps of implementing it in terms of contacting us, what we would have to have organized. But we can certainly work through that for anybody who is interested in implementing this, and hopefully you are, and we can, as we talked about, make some comparisons and learn across OHTs. It will be a really great opportunity. Are there any more questions for our panelists before we conclude? I'd like to say, really great work and sharing. I think there's a lot of insights that you've shared, and I think really just hearing your honest reflections about what's important is really, really enlightening, and how we can use this survey.
And for taking the time out of your busy days and hoping that we didn't add burden to your already burdensome situation.
And then I can share my screen, I'll just highlight that we have a couple more, we're continuing our trip around the Quadruple Aim with the other two series. So next up in June, we'll be talking about health outcomes and measuring health outcomes. And then in July, looking at cost. And just, there's a couple pictures of our team behind the scenes that are making all this happen. And I think that's it. I'll just check the chat. So no more questions. And again, thanks very much for everybody, all the participants who asked the great questions and took time out of their day, and of course for the panelists and those at Couchiching OHT for sharing your experience. So thanks everybody, and a couple of questions in that chat for thanks as well. I hope everybody has a nice week. Bye everybody.